Bronchiolitis. Key points. Bronchiolitis is a clinical diagnosis. No investigations should be routinely performed. Management includes supporting feeding and oxygenation as required. No medication should be routinely administered. Background. Bronchiolitis is a viral lower respiratory tract infection, generally affecting children under 12 months. It is a clinical diagnosis, based on typical history and examination. Peak severity is usually at around day 2 to 3 of the illness with resolution over 7-10 days. Usually self-limiting, often requiring no treatment or The cough may persist for weeks. Assessment. Red flag features in red. Bronchiolitis typically begins with an acute upper respiratory tract infection followed by onset of one or more of cough, tachypnea, retractions, widespread crackles or wheeze, fever. Risk factors for more serious illness. Chronological age at presentation less than 10 weeks. Chronic lung disease. Congenital heart disease. Chronic neurological conditions. Indigenous ethnicity. Immunodeficiency. Trisomy 21. Infants with any of these risk factors are more likely to deteriorate rapidly and require escalation of care. Consider hospital admission even if presenting early in illness with mild symptoms. Assessment of severity. This table is meant to provide guidance in order to stratify severity. The more symptoms the infant has in the mild severe categories, the more likely they are to develop severe disease. Mild. Behavior, normal. Respiratory rate, normal mild tachypnea. Use of muscles. Nil to mild chest wall retraction. Moderate. Behavior, some/intermittent irritability. Respiratory rate, increased respiratory rate. Use of accessory. Muscles. Moderate chest wall retractions. Suprasternal retraction. Nasal flaring. Severe. Behavior, increasing irritability and/or lethargy fatigue. Respiratory rate, marked increase or decrease in respiratory rate. Use of accessory. Muscles. Marked chest wall retractions. Marked suprasternal retraction. Marked nasal flaring. Oxygen saturation/oxygen requirement. Mild. Oxygen saturations and GT 92%, in room air. Apnoic episodes. None. Feeding. Normal. Moderate. Oxygen saturations, oxygen requirement. Oxygen saturations 90-92%, in room air. Apnoic episodes. May have brief apnoea. Feeding. May have difficulty with feeding or reduced feeding. Severe. Oxygen saturation/oxygen requirement. Oxygen saturations and LT 90%, in room air. Hypoxemia may not be corrected by oxygen. Apnoic episodes. May have increasingly frequent or prolonged apnoea. Feeding. Reluctant or unable to feed. Management. Investigations. In most children with bronchiolitis no investigations are required. Investigations should only be undertaken when there is deterioration or diagnostic uncertainty, e.g. cardiac murmur with signs of congestive cardiac failure. Chest X-ray, CXR, is not routinely indicated and may lead to unnecessary treatment with antibiotics. Blood tests, including blood gas, FBE, blood cultures, rarely have a role in management. Virological testing, nasopharyngeal swab or ASPI rate, has no role in management of individual patients. Treatment. Blank. 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 Mild. Likelihood of admission. Suitable discharge. Consider admission if risk factors present, observations, vital signs, respiratory rate, heart rate, oxygen, saturations, temperature, adequate, Assessment in ed prior to discharge, minimum of 2 recorded measurements, or every 4 hours. Hydration, nutrition, small frequent feeds, oxygen, saturation/oxygen requirement, nil, requirement. Disposition/escalation, consider further medical review if early in the illness and any risk factors are present, or if child develops increasing severity after discharge. Education, parental education, provide advice on the expected course of illness and when to return, worsening symptoms and inability to feed adequately. Moderate likelihood of admission, likely admission, may be able to be discharged after a period of observation. Management should be discussed with a local senior physician. Observations, vital signs, 1 to 2 hourly, not continuous. Once improving and not requiring oxygen for 2 hours, discontinue oxygen saturation monitoring. Hydrations, nutrition, if not feeding adequately, and LT 50% over 12 hours, administer NG hydration. Oxygen, saturation/oxygen requirement, if oxygen saturations fall below 90%, administer oxygen to maintain saturations greater than or equal to 90. Once improving and not requiring oxygen for 2 hours, discontinue oxygen saturation monitoring. Support. Begin with nasal prong oxygen. Blank. Dispositions, escalation. Decision to admit should be supported by clinical assessment, including risk factors, social, geographical factors, and phase of illness. Education, parental. Provide advice on the expected course of illness and when to return, worsening symptoms and inability to feed adequately. Severe likelihood of admission, requires admission and consider need for transfer facility/PICU. Threshold for referral is determined by local capacity but should be early. Observations, vital signs, hourly with continuous cardiorespiratory, including oximetry, monitoring a nursing observation. Hydrations, nutrition, if not feeding adequately, and LT 50% over 12 hours, or unable to feed, adminis. Oxygen, saturation requirement. Administer oxygen to maintain saturations greater than or equal to 90%. Support. Blank. Dispositions, escalation. Consider escalation if severity does not improve. Consider ICU review/admission or transfer to LOC. Pediatric HDU/ICU capacity if severity does not improve. Persistent desaturations. Severity does not improve. Significant or recurrent apnoea associated with desaturations. Has risk factors. Parental education. Provide advice on the expected course of illness. Oxygen therapy. Oxygen therapy should be instituted when oxygen saturations are persistently and LT 90%. Infants with bronchiolitis will have brief episodes of mild/moderate desaturations to levels and LT 90%. These brief desaturations are not a reason to commence oxygen therapy. Oxygen should be discontinued when oxygen saturations are persistently greater than or equal to 90%. Once not requiring oxygen for 2 hours, discontinue oxygen saturation monitoring. Continue other observations 2-4 hourly and reinstate intermittent oxygen monitoring if deterioration occurs. Hydration/nutrition. Children are often more settled if comfort oral feeds are continued. When non-oral hydration is required, nasogastric, NG, hydration is the route of choice. If for fluid is used, it should be isotonic with added glucose. Blank. assessed as moderate or severe bronchiolitis. Medication. Medications are not indicated in the treatment of bronchiolitis. Do not administer beta-2 agonists, including infants with a personal or family history of atopy. Corticosteroids, nebulized, oral, intramuscular, IM, adrenaline, nebulized, IM or 4, except in peri-arrest or arrest situation. Nebulized hypertonic saline. Antibiotics, including azithromycin. Antivirals. Nasal suction. Nasal suction is not routinely recommended. Superficial nasal suction may be considered in those with moderate disease to assist feeding. Nasal saline drops may be considered at time of feeding. Chest physiotherapy is not indicated. Consider consultation with local pediatric team when discharged prior to day 3 of illness with other risk factors, detailed in assessment section. Abnormal oxygen saturations. Less than half normal oral intake or urine output. Assessed as moderate or severe bronchiolitis. Consider transfer when severe bronchiolitis, see above. Risk factors for more severe illness. Apnoea. Child requiring care above the level of comfort of the local hospital. Child has oxygen requirement and GT 50%. For emergency advice and pediatric or neonatal ICU transfers, see. Consider discharge when child maintaining adequate oxygenation and maintaining adequate oral intake. Note: infants younger than 8 weeks of age are at an increased risk of representation.